Good morning. I must say I'm really pleased to be here this morning. I was really looking forward to this conference. So my presentation is called the Tango. And, well, I'm very fond of Argentina. I mean, but it's more than that, because really the healthcare professional and the patient both have different roles and behaviors, but ultimately the result is complementary. For example, if I'm feeling very tired and start a meeting with a patient and look at the patient and say, "Oh my God, you look really tired." And the patient says to me, "Well, really, no, I'm not." Well, it's an example of something that is going on in me that I end up depositing in the patient. And this is part of the tango. Just like the physician who's been up all night with a sick child and has to deal with a patient in the morning. It can be a very difficult situation. Let me see here. So I had another, whoops. I really wanted to put this Nietzsche quote, because for me, the most important part of this tango is the self-care of the healthcare professional. And Nietzsche said, physician, help yourself. Thus you help your patient too. Let this be the best help that he may behold with his eyes, the man who heals himself. So back to the tango. One of the things I was very surprised as I started to think of this presentation, I had not realized that the rate of burnout in physicians is as high as 60%, and that the suicide rate is one of the highest, of all the professions. So this was a bit of a surprise for me, and that's where I started to really think about self-care. And as a patient said to me one day, I took the plane the other day and I paid attention to the oxygen demonstration, because what they say is, if you need to help someone, make sure you put your own mask on first. So, to me that is a very important part of keeping this tango in shape. Okay. There are loads of barriers to self-care. I mean, I must admit, I was very surprised, because I interviewed a number of physicians, and I was very surprised to hear their distress and to hear them talk about the constraints of the system and the pressures that exist. So some of the barriers are definitely time constraints. And there's also limited resources. For example, the physician who wants to consult a therapist because he or she is feeling depressed can have to wait a very long time in order to be able to find someone. And I think many of you who are in the field who attempt to refer patients, will connect with what I'm saying. The other thing is that has come up in the interviews is the limited opportunities and time to talk with other colleagues about issues and about what is going on. And so basically, some of the guidelines for self-preservation, they include, working within the confines of skill set. End up with a patient that you don't feel capable of dealing with, you can always ask for a referral. However, there's all kinds of things at play there. There's the desire to be able to take care of. There's the shame for some people in asking for help. The other thing that's really important is the issue of boundaries. Boundaries are like a cell membrane. They don't allow everything in and they don't allow everything out. but they ensure that relationships can be mutually respectful, appropriate, and caring. This is the way of setting some limits. I mean, ultimately, asking for help, treating depression, and attempting to keep a balance in life, they're all basic things that are extremely important. I'm not familiar with the healthcare system outside of Canada, so my comments are more focused on Canadian experience. The average length of a doctor's appointment these days has scrunched down to 13 minutes, according to the National Ambulatory Medical Care Survey. Barely enough to say, hi, how are you? Order a blood test and fill out the required paperwork. You know, how can we choose between a healing balance with the environment, with compassion, human service, evidence-based technology, and economic viability? I mean, those are very difficult situations. Recently, I spoke with an emergency room physician who talked to me about starting her shift with 40 people waiting. And one of the things she said, sort of self-care, is that she learned not to feel guilty because of the people having had to wait for so long. And she sort of reorganized, she had a look at the people who were there and redid the triage in a way, because she focused a bit more on elderly people. She didn't want them to go home in the middle of the night with absolutely no resources. And when she addressed a patient, the first thing she would say to them is, you know, I realize that you've been waiting quite a long time. And she says that to her surprise, there are very few people who become angry at her. This is very, very rare. But what a way of establishing a connection, acknowledging what the other, you know, has had to deal with. Sometimes she said she became really worried about diagnosis and treatment plans, and in Emerge, things move quickly. And so what she did is she started a group of physicians that could anonymously talk about situations that have been difficult for them. Because this is one of the things that she finds is really missing, is the possibility to talk to colleagues. It's interesting, another ER physician that I talked to basically said, there is no space for empathy in Emerge. People come and they're either sick and they're not sick. So I say, well, what's not sick? Well, somebody with a urinary tract infection or an earache, they're not sick. So, interesting. In Canada, physicians are largely paid by the act. Now, some physicians' reactions to this, I interviewed a number of administrators also, and to learn that some physicians' reaction to this is to book several appointments at the same time slot. So, of course, the outcome, I mean, obviously, they compensates for no shows, and, you know, financially it's worth it. But it also decreases the available time for them to see patients. And patients have been waiting, and the physician starts to feel pressure, and that is picked up by the patient. And, you know, the patient ends up feeling that the physician is completely rushed, and both can end up experiencing in their tango, if you will, a lot of anxiety. The other thing is, in addition to being rushed, today the physician often has his or her back to the patient, glued to the screen, because the screen tells you everything that's going on inside a patient. You don't really need anything else. The screen has it all. So the patient is left to their own devices while the physician is looking at the screen, thinking of treatment, you know, diagnosis, what could be done. And So it's not something that leads to foster a very good relationship. So what I want to do is I want to read you a little vignette. It was written by an oncology patient. Whoops, I'm crunching ice. That's a new one. And the vignette was written by an oncology patient after her monthly appointment with her physician. The vignette, I picked it up on a website called Health Unlocked, and it's a website that deals with metastatic breast cancer, and women exchange things. So this is where I got this vignette, because I thought it was worth. So I'll go through it. What I'd like you to do, though, because I want your feedback, I'd like to have your comments about what you think happened, what you think could have happened, and any issues that you might have. So here goes. So this is the vignette. So here we go again. I've walked out of my oncologist appointment feeling utterly frustrated. A year on, and I still have not succeeded in maximizing that 5 to 10 minute monthly golden encounter. Every time I rehearse in my head what I want out of it, the questions I have, the tone I want to use, the persona I want to present, the options I want to discuss, and pretty much every time I fail miserably. Now, to my defense, I have to prep a range of scenarios, as I never know who I will see and how much of my file they've managed to digest in the 3 minutes prior to seeing me. But I do always factor in that when I rehearse my performance, and yet, more often than not, I just walk out feeling a mixture of worried, angry, frustrated, and so on. So, last week was no different. I'd worked out that I was likely to get the fellow. I also knew she would have nothing of significance to say, since I'm only on cycle 2 of my second line of treatment. But despite this, I somehow had got myself in a place of expectations. Now, what was I expecting? I'm not sure, to be truthful. But what I got wasn't it. Having covered the expected, we have to wait until the next PET scan in September to see the results. She moved on to, how are you feeling? Now, of course, I knew she did not mean to ask me how I was feeling emotionally. No time for such nonsense. This was merely a code to check for side effects. But I probably subconsciously, intentionally, if that makes sense, chose to take the question in its literal sense. I answered that actually the last 2 weeks had been a tricky journey, that the 2-step process that gave me an unexpected and serious disease progression, followed shortly by an offer of a clinical trial, only to be taken away 2 weeks later, had knocked me a bit and left me vulnerable. I explained that I'd bounce back, but I still felt I was grieving the end of a treatment, and that left me feeling like I was back on default setting, a protocol. I added that my understanding was that my cancer was behaving aggressively and unexpectedly, and that the door to a more targeted approach had been slightly ajar, only to be slammed right back. This sounded like the second line of treatment, and was therefore more, that's all we have to offer, you have nothing to lose, rather than, this should do for a bit longer. She just listened to me and nodded. I felt like saying to her, don't nod. I am trying to be clever here by sounding all grown up, but this is your cue for you to say something like, early days response is not actually that unusual. But she didn't. She nodded in acceptance and asked me if I had help. I looked back at her a bit puzzled and asked her to clarify what she meant, only to realize she meant counseling. I felt so patronized. I felt I had crossed the untold, but known by all, secret lines like a naughty child. I really felt she didn't care what I felt and wanted me out of the room. Because of that, I walked away not knowing what to read into her nodding. Was it an acknowledgement that I was pretty much spot on, but that their hands were tied up by available, or in this case, unavailable protocol? Or was it simply a way to try to get me to stop with the emotional diarrhea she was obviously so uncomfortable with? I was none the wiser, and since I won't get to see her for another 3 months, I'll just have to wait for the PET results. I walked out feeling so cross with myself because I was leaving with more questions than answers, and then realized that the day I walk out of one of those appointments with certainties, it will probably be bad news. So that uncertainty was probably a good place for now. So I'd really like to hear your comments about this vignette. I mean, if we're thinking of tango and we're thinking of relationship, you know,
Stiff tango.
yeah. No comments? Yes.
So I wonder why the patient doesn't say more.
Hold on, Roy, just a sec.
How much time do I have?
8 minutes.
So I wonder why the tango, why the patient doesn't feel more free? Is it the time
Can you
limitation?
get it close to the microphone?
Is it the time limitation? Is it that she's being sort of told unconsciously not to ask these questions? I mean, in my own situation, when people say that they forget to ask things, and I often ask them to write a list of questions and sometimes email them to me before they come to the appointment, so I know what to expect.
Mm-hmm. Well, I think the issue here is that there's no relationship, there's no connection that's been established. You know, for example, if instead of saying, are you getting help, do you have counseling? The person could have said, like, I'm wondering what's going on and I'm wondering what you're concerned about. Could have helped to explore that situation as opposed to coming up with a recipe. I mean, I read a quote the other day that maybe will explain this. And the quote is, "The patient views the doctor as a means of getting a pill, and the doctor views the patient as a biochemical imbalance to be manipulated by a pill." I mean, it's, you know, a wonderful example of, you know, giving an object to an object, giving a pill to a person, but there's no connection. You know, the connection is really what is absolutely crucial. I think you said I've just got 8 minutes left?
Yeah.
Okay. So, given that are any other comments on this vignette? Yes.
Marta.
Thank you. What struck me about this is, number one, that she never knew who she was going to see when she went to the clinic,
Mm-hmm.
which is a terrible way of treating patients.
Mm-hmm.
And the other is that she felt that the onus was on her
Mm-hmm.
to make the interview go well,
Yes.
which and it should be the opposite.
Absolutely.
So this is, I mean, it's very bad medicine.
Absolutely.
I'm just a home care nurse, and so the clients that I sorry, I see clients that come home after these meetings, after the tango, and that's my great joy of my job, is I get to talk to clients that when they didn't have a good meeting with their doctor, or they're waiting 3 months, I go in between, and what I've noticed is they don't have GPs, that oncologists might or might not be there. Maybe they'll see the practitioner. Maybe they'll see a dermatologist and not an oncologist or an oncological surgeon. So they don't know, they're just going from specialist to specialist without the whole picture. So a lot of it is navigating through what is the disease, what are we looking at. This client who's 90 years old doesn't know the system. And so I get to sit there on an ottoman close to her and listen to what's happening to that journey. But I have no control over it. She doesn't have any control over it. And the doctors don't have control over it either.
Yeah.
Hi, thank you. That was really excellent. I know you're not done yet, but with my interest in medical education, it helps to let us reflect on how and where we are missing the mark in training and setting up our expectation for medical students and residents. And this is something that's missed, I think, there's a hidden curriculum beyond medical school, and this is something that is missed. We're not teaching it very well. So that's actually my area of research.
Okay.
I might want to defend the fellow a little bit here, because I'm not sure. I mean, obviously, we don't know what the tone of this patient was, but she sounds very anxious, and she expresses what she calls emotional diarrhea, right? So she's going on about how anxious she is about her situation, and the fellow is nodding, kind of taking it all in, and then suggests that maybe she needs a counselor. Like, that doesn't sound like such a terrible interaction to me. So, yeah, that's
No, I agree with you that it's not a terrible interaction, but it could have also been a bit more opened, like getting the patient to talk about her anxieties and her worries, as opposed to coming up with, almost like a prescription. But I agree with you, it's not a terrible, but I mean, obviously this patient had a really hard time. She was not a very happy camper after her meeting. Given that the time is going really quickly, I'm going to skip some things here, because one of the things that I find is very interesting about this this conference is the whole idea of caring versus curing. And I want to give you an example of a situation where curing or fixing is just not possible. It just cannot happen. And this has to do with a 49-year-old African illegal immigrant that I work with. He's been here for 6 years. He left his African country urgently because he was going to be killed. He left his wife and 7 kids and came to Canada with fake papers, was detained at the airport, but they let him in. So then he went to court, and although he speaks French, the judge insisted that he have an interpreter. And in his culture, looking at somebody in the eyes is considered very impolite. So he was not allowed to speak in court except through the interpreter, and with not looking at the judge decided that he was lying. So he was ordered deported. He had escaped from jail, sold basically everything he had to get the fake documents. It had to jump over a big wall, hurt his knee, which continues to be a problem. But after the deportation order, he became obviously extremely anxious. He wouldn't even leave his room. It took some while to help him realize that, he's a very good-looking man, tall, black, but that, Montreal is so multicultural that it's highly unlikely that he'd be picked out. But, listening to, watching his resilience, his ability to get an apartment, to get somebody to sign for him. He can't have a bank account. He can't travel out of the country. But his ability to get clothing, to get food. He's diabetic. Luckily, Doctors of the World has a clinic, because otherwise he would have no access to health care. He's gotten a lot of help to deal with his health situation. He's doing, his diabetes has been under control. But when you look at this man, like he's lost his family, he's lost his country, he's lost everything that is familiar. Like even looking outside at nature, it's not the same. He talked so much about the fear when he first came. He'd never seen an elevator. I mean, he was a mason and he worked in fields. He'd never been on a plane. An escalator was something extremely frightening to him. But when you look at all the losses and this chronic difficulty, I mean, now he's decided that he wants to ask for another humanitarian demand. But the likelihood, first, A, it will take a long time. B, there are very good chances that he won't get it. So I've been seeing this man for over 2 years, I can't fix anything. All I can do is offer him a space, offer him a presence. It's very interesting. When one of the first times I met him, he called me Mummy. I thought, oh my God, like what is going on here? But I learned that in his culture, an older woman is called Mama. So this is what was going on. It was. I guess that also highlights the importance in terms of relationships of learning about cultural differences, because we have different ways of seeing things, like, looking in the eyes, for example, calling somebody mummy, So basically, that's basically what I wanted to talk about, So anyway, this guy is doing reasonably well. He really wants to do the humanitarian request. He says, I need to have some hope. I need to have some hope. It make you think sometimes of patients who are very ill also, who need to have some hope. But that's it.
Thank you.
Hello, I'm very honored to be here with you today to share some of my thoughts. So the first thing I was asked to say is that I have no conflicts of interest to declare. So I've seen my share of patients over the year, initially as a baby learner at the beginning of my medical studies, and now I've evolved into a forever learning. I'm lucky to have the chance to teach, and I'm reminded every day of the real value that my patients bring to my life. They are the reasons why I look forward to heading to work every day, and I now know that they are my best teachers. The lead up to the encounter. So let's start with what usually brings patients in to see us. Dis-ease. This is not starting well, is it? They're already not at ease. They may be scared, they may be sleep deprived, they may already have diagnosed themselves with a rare form of an illness that we've never heard of after scouring the internet. They may or may not be particularly trusting of the medical system, and that may or may not be based on previous encounters. And then there's this medical fellow who looks very much at ease, and he also looks like he may have all of the answers. So we speak of power differentials in medicine between physicians and patients, and so this dis-ease already creates an imbalance, and there are other factors that collude and contribute to widening that patient-physician divide. So when we round in the morning or have patient rounds, I sometimes hear an expression that really makes me bristle. So have you heard this one? Known case of asthma, bronchial asthma, known case of. So how do you think the patient feels if they hear these words? I mean, it makes me uneasy, but I can't imagine how a patient feels. And I mean, yesterday at supper, we had the best example with Marek Bazik, who looked down at his little thing here and said, I'm not a surgeon, I'm a person. So even we can feel some of that. So labels create distance, anonymity, othering. Thank God it's not me. They can be limiting, depersonalizing, demeaning, reductionist. So we assume that they are the whole picture. But the reality is that behind that label stands a real person and all of their complexity with challenges and unique dreams and aspirations. So now for the really tough questions. I'm hoping you've all had your coffee this morning. Okay, so I'd like for you to tell us, in your experience, what are specific diagnoses, scenarios, and patient characteristics that cause discomfort in treaters? So it doesn't have to be in you. You can imagine some of your colleagues. So what are the patients types or scenarios that make physicians almost sigh before they're about to go into the room? Can you give us some examples? Patients with borderline personality disorders. Mm-hmm. Patients with pseudo seizures. So patient with maybe somatization or those kinds of, yes? Mm-hmm. Fibromyalgia? Yes? Passive aggressive patients? Absolutely. Thank you for that one, because there's lots of literature on that now. And patient, obviously patient accounts. Yeah, patient talk about it a lot. What else? What other patients? Sorry? Yes, patients with polysubstance abuse, absolutely.
Frequent flyer.
Yes, I'm very happy you said this expression. Yes,
Frequent
flyer patients. Like in the Emerge, right?
Frequent flyers.
Yeah. What else? Yeah.
Patients who come in with 6 or more family members.
Yes.
Those are the
Excellent.
Italians.
Yes, very good. You guys are doing great. It's exactly. Anything else? Yes.
This goes under the general category of the famous article on the hateful patient.
Yes. Yes.
The hateful patient.
Right. Imagine that. Yep. Good. What else?
I would have patients who've been to see several providers before.
Yes.
Patients
So
here for a third opinion or a fourth opinion.
the patient who shops, right? The patient who shops around? Yeah. What about the patient who comes with a list of problems? You know, when it's like 6 or more problems? Yeah? That patient, when you know you have a limited amount of time? Yeah.
Who comes with 60 pages printed from the internet.
There we go. This is excellent. You guys are doing great. Yeah. Keep going. What else? Anything else? So what I've heard sometimes, you know, in Emerge, I'm listening. So sometimes patients with obesity. Sometimes it's patients with eating disorders, right? What about the patient with mental health problems? When the provider doesn't feel comfortable, is not identified as a mental health provider. So I think there are many examples. You've come up with really a lot of them. So my next question for you is, what feelings do these diagnoses, scenarios, or patient characteristics evoke in treaters? Helplessness. There you go. What else? Yes, anxiety. What else? Frustration? Stress, absolutely, because of time constraints, right? And like awareness of patient flow. Yes. Emotionally drained. Yes. Mm-hmm. Even before you start. Right? Sorry? Inadequacy. Yes. Sometimes impotence, right? Yeah. What else? Well, really, certain patient types and scenarios may confront professionals to their limitations and sometimes to their lack of knowledge in a particular area, or preparedness, or lack of an approach to a problem. So seeing these patients requires humility, respect, a non-judgmental approach, inclusivity, ability to self-reflect, and willingness to learn and to be taught. So we are trained to know a vast quantity of facts in medicine and to be able to fix, cure, console, and put back together. Ours tends to be a profession where we're trained to fix things. But what if we cannot? What if we miss the point? There are pearls to be collected during each patient encounter, but what if we're missing out? There are many facets of the patient encounter that are bound to suffer from our biases, which may be conscious or unconscious, starting with just the history taking, the physical exam, coming up with a differential diagnosis. For example, coming to a premature closure, saying, well, it must be this, it kind of look like this, or pigeonholing the patient. in terms of diagnosis. And then treatment recommendations, which can really influence patient compliance with treatment and follow-up. So I see this as faulty building blocks. You start with the wrong blocks, and then everything that comes after, the subsequent steps in the encounter and beyond may be faulty as well. And it's important to remember that the effects of a meeting with a patient can have very long-lasting effects. So how bias blinds us? So I have 2 patient stories to share with you. I'd have many others. I can share some outside of this talk. But I really want to come to 2 important cases. So the first one was a 30-year-old patient. It was not my patient, so it's a story that I've been told, who was known for depression. So his depression started after a particularly bad breakup, romantic breakup. And he was starting on an SSRI, and he was seeing a therapist off and on. And he'd been on the SSRI for years, and he started going back to his doctor, complaining of increasingly severe headaches, nausea, that progressed to vomiting, and dizziness, and fatigue. And he was seen multiple times over the course of 6 to 12 months, and his symptoms were assumed to be part of the depression, and or were assumed to be part of possible medical side effects. This patient eventually had an MRI and an LP and was diagnosed with CNS melanoma, and he died within a year of his diagnosis. The second case was not one of my patients, but was told to me by one of my psychiatry colleagues, and it's probably the best story I've heard. And it was a patient who was being seen in the emergency room, in the psychiatry emergency room. So they came into the normal emergency room, and they got quickly switched to the psychiatry emergency room, and this patient had the label of a frequent flyer. So it was a lady, and she was wearing a trench coat. And so the psychiatrist who spoke to me was then a little resident in psychiatry, first year starting out, and he was told by the staff, patient has history of psychosis, just get this patient admitted, just go to the ward, just admit it, just admit her, and she's it should be very easy, just go do the admission. So the resident kind of looks at the complaint, and the complaint was back pain. So he said, well, shouldn't we be looking into this back pain? And the psychiatrist said, no, whatever. She's the patient with psychosis. Just go and do the admission. And so, but she kept complaining about back pain and back pain and back pain. And at some point, the resident says, after hours of the patient being on the ward, they convinced her to take off her trench coat. She had a knife that was planted in her back between her scapulae. So this is when we really talk about, and it's a true story. I mean, I got him to like swear that it was a true story. It was a true story. And this happened in the United States. So we, it did not happen in Canada, okay? So, just saying. So I'm talking here about making assumptions, right? Disregarding red flags. I mean, hello, there are some red flags here. I'm sure the trench coat looked like this in the back, like there's a knife planted in the back. So I'm talking about not entertaining the possibility of a new or concurrent organic illness when a patient is already known for a mental health diagnosis. And this happens all the time. So it's very important to be aware of that. And I would say, when in doubt, let's just remember where we all started. Beginner's mind. So in this case, I would just want to bring up two cases. So the first one is one where I was still in medical school, and how it works at McGill is you get to interview your first patient, and the second patient, you just take a history, and you know nothing at this point, and you're not even told what diagnoses they have prior to that. So I was assigned 2 different patients. My first patient had I know there's a new term, but it was then known as Wegener's granulomatosis. So it was a very severe rheumatological disease that can be life-threatening. So I saw this patient. He was wonderful. I then went home and studied the book, right? I studied that disease. And then I come to a respirology elective as a little medical student around Christmas time. And then they just tell me to go interview a patient who has on his dossier a diagnosis of tuberculosis. So I start taking a history, and remind yourselves that I know one diagnosis, but I know it well, right? I know diagnosis. I know nothing about tuberculosis, right? And so I start taking my history, and so I ask him about migratory arthritis, and obviously in words where he can understand. And I was like, oh, actually, yes, and so okay. And then I ask him about, history of sinusitis, and everything I'm asking is like lighting up. So I think, okay, but it says tuberculosis, who am I, right? And so I remember from reading that it's not a bad idea to get a UA, because if you see red cell casts on the UA, then that could align with the diagnosis. So in those days, we were allowed to do our own UA. So I go and do a UA and look, and lo and behold, under the microscope, red cell casts. So I go back to my staff, and I think, well, who am I, right? So I go back to the staff and I say, I don't know, I know this diagnosis, but I just happened to see this. And I said, I saw red cell casts on the urine. And so the staff looked at me and said, really? Like, maybe you should wait to be at a bit of a higher level before you start looking at it. So he didn't even have, even the curiosity to go and look and say, come on, right, this is not a red cell cast, this is a, white cell. He didn't even have the curiosity to come and look with me. So fast forward, patients who are treated for tuberculosis are treated with multiple therapy, but they are not treated with steroids. This was a father with 3 children who spoke to me about his wife and children, because a medical student had a lot of time, so we spoke about his family, and so I knew some stuff about him that maybe some of the others didn't. And he died over Christmas. He died over Christmas, and his diagnosis was Wegener's. So again, this is a huge bias, right? Because remember, I knew one diagnosis. I asked the questions. It was a fluke. He had it. But this patient died. This man who had a wife and had 3 children died. And they died maybe because there was a lack of curiosity, right, for this patient. And I'm never going to forget that case. So the other case was when I was during my fellowship, and I was doing a split fellowship in adolescent medicine and ER, and during my adolescent medicine part, I get a call from a fellow in Emerge, an Emerge fellow who calls me and says, you need to come and help us with this patient, this teenage girl, 15, has pelvic pain. She's not sexually active. We don't know what's going on. 4 people have seen her. The medical student has interviewed her. The pediatric resident has interviewed her, the ER fellow has interviewed her, and the ER staff. And these were good people. And this ER staff was somebody I admired, and I just thought, I was very intimidated. I thought, what am I going to add? What kind of value can I add to this assessment? So I went into the room, and so first I said the kid was alone in the room, and she was very overweight, and she was wearing very baggy clothing, and she had quite a bit of acne and hair, so she probably, at a glance, had a diagnosis of polycystic ovarian syndrome. She didn't look happy. She looked kind of sad, and I just really didn't know where to start with her. I really didn't, because I had all this information that had been told to me, and I thought, I'm not sure I can add anything. So I kind of looked at her and I said, are you here alone today or with somebody else? And she said, no, I'm with my mom. And I said, where's your mom? And she said, in the waiting room. So I said, okay, I'm sure everybody's done this with you, and I'm so sorry. I said, but I'm just going to start from the beginning. So I'm just going to say that in Quebec, when you are 14 and over, you have a right to confidentiality. What that means is anything that you and I discuss today will remain private between you and the medical team. That means I cannot tell your mom unless you say that is okay. And I gave her then the exceptions to that. So we went through the 4 exceptions to that. And then I said, is that a good place to start? And she looked at me, she said, nobody told me this. I had no idea. I said, okay. So I said, so now I need to ask you a difficult question, and I'm not asking it out of curiosity. I have to ask you this question because you're coming in with this abdominal pain, and I need to be able to decide what's possible. And I said, depending on what you tell me, I may or may not think of the right problem. So I said, I need for you to tell me if you've ever had sex before. Because using the expression sexually active for teenagers, we were talking about last night, This is not language you use with a teenager because they'll tell you no, because they just lie there, they don't move. So this is something that's happened, right? Or the boy, we're asking him, are you having sex? No, actually, I'm talking to you right now. So there is a way to talk to teens, right? So they're teaching me, right? I learn. Clearly, I've been a very bad historian over the years, but they're trying to, they're working with me. They're trying to mold me into a better historian. And so I asked her this question, and then she kind of hesitated, and she said, actually, yes. And I said, I said, so is this something that's happening? Is with a boyfriend, or a girlfriend? Is that? And so she said, actually, no. And she said, it's a bit embarrassing. She said, I've been bullied my whole life, and I have not had any friends. And suddenly there is this boy who is the most beautiful guy in the school, and he's the sportiest guy, and he has a beautiful girlfriend. And he told me that if I wanted to be part of this gang, which is like the royal gang of the school, he would allow it as long as I did these sexual favors for him. So this kid is being sexually abused by this boy, and she had PID. But you see how this, and PID, pelvic inflammatory disease, which is due to a sexually transmitted infection, because if he's doing this to her, he also has a girlfriend, well, who knows? He's probably doing this with other people too. And so this diagnosis could have been missed, and it's a diagnosis that can have far-ranging implications for future fertility, chronic pain, and then the risks of ectopic infections. So I was truly at risk in this case of doing a copy-paste error, right? I mean, with the first patient, I was at risk of doing, as a little medical student who only knew one diagnosis, I was at the greatest risk of doing a copy-paste error. I just had, by luck, I had narrowed in on the right thing, but that was just purely, that was luck. It was a coincidence. In this case, I was really at a risk of doing it, especially because esteemed people who I trusted and were my trainers, were my mentors, had told me, look, don't even go ask that question. She's not, and just go and tell us what you think she has. And I just wonder how many times and how many of those I've done copy-paste errors. So reflecting on the topic of this conference, the risk of medicine, there is a real risk of missing the point of the patient encounter. There's a real risk of missing the patient's point of view. At times, the patient-doctor visit can be resumed or reduced to shopping lists, different agendas. It's like a Venn diagram without a connecting spot, so it's like two circles that don't meet. So patient and physicians can be like two ships crossing in the night. How to avoid this, I think, is to listen, ask, be curious about the patient and their life and their dreams. So this requires humility, attention, genuine interest. It requires you sometimes to be rested. I try to tell the students, and I do this when they're writing their impression plans, when they write impression plans stable, I say, can we have a discussion about this? What is that? So I want them to, I said, you need to manifest in your, and I'm a stickler for impression plans, you need to manifest in that impression plan, in your documentation, the complexity and the unicity of the patient. So I tell them, what makes this patient with asthma different from every other patient you've seen in your life? What makes this patient with anorexia nervosa truly unique in the world? So that when you go back to that chart and you glance at your impression plan, you know where you need to go. And it's as if, if you're sick, somebody else has to look at your chart, they feel they saw the patient themselves. Remember the power of words. So look at patients when you see treaters telling them, oh yes, I know, I can just imagine. Look at their faces. They don't respond to that very well. And a last word on further humanizing the patient-treater contact is the importance of body language, which speaks volumes, the importance of eye contact. For me, the power of the human gaze is limitless. With the H1N1 and flu and all these things, the medicine is increasingly becoming a very aseptic world. People, handshakes is not commonplace anymore. When I was in the emergency room, I'd sometimes run into the crash room, and I would see the resident like this, and looking at the machines very carefully, and I'd say, have you taken a pulse? No, but look, it looks like an arrhythmia. Okay, I see that. Have you looked for a pulse? Because that will influence what the final is. Have you taken a pulse? Have you checked? And if the patient's perfused, so people are not touching the patient anymore. When they come to the adolescent clinic, we do postural vitals on our patients with anorexia nervosa, and I can see them trying to use a blood pressure cuff, and they're fumbling. It's very, very difficult for them. When I see my eating disorder patients who've gotten a lot better, and this is just to show how important touching a patient is, and we're talking about, like just when we're examining patients, sometimes there comes a point where I don't need to do postural vitals anymore because they're better. And I've had patients tell me, "You're not doing my blood pressure?" And I said, "Well, no, we just did it, we just did it this way." Like, no, you are doing my blood pressure. Like so they see it as an expression of caring. And as I stop doing that procedure, they see it as an end to the caring. So I think they were frustrated when I first was doing the postural vitals, and now they come to expect it and see that it's part of caring. What you convey in your patient visit is really important. I think what you're telling them is, I see you, I acknowledge you, you matter, or at least I'm trying, I hear you. And that's what I had to say. Thank you.
I would like to thank the founder, first of all, and also Max, Christina, and Cristiano for making this happening today for me. So I want to talk about this special bond, this patient and healthcare professional relationship, but more the human-to-human connection, which is very important in our practice. So I graduated in 2017 with a Master's of Physiotherapy, did a bachelor's degree, ended in 2015. And before that, I did a bachelor's degree in microbiology at the Université de Montréal in 2012. I currently work at the Douglas Hospital 3 times a week. Also did some work at the Lakeshore Hospital in surgical and medical units. I worked also in a private clinic and as a personal trainer too. I don't have my 6 packs anymore, but. So, Therapeutic Alliance. When did it start? When we started discussing about it, looked in the research, and this amazing man, started with the theory of transference, which was negatively viewed at the beginning, because what he said was we unconsciously transfer the feelings of someone very significant to us to the person that you see today, right? So if the person today, your doctor, makes you think of your dad, you're gonna project the same feelings. But what if it's your ex-wife or your ex-husband? And then later on in the 60s, more work came out, and we started talking about this collaboration between the patient and the therapist. This man, Lester Lubarsky, who was one of the founders of psychotherapy research, suggested that alliance is very dynamic, and you have a lot of variations throughout the journey with your patient. You're gonna have up and downs, and which is normal. And he suggested two phases. The first phase, which the development phase, where you try to connect with the patient. And you need 3 essential elements for this. You need to agree on the goals of the treatment with your patient. You need to agree on the task, how you're gonna tackle those goals. And you need to develop this trust relationship with your patient. And if you don't achieve these elements, your patient will not accept, will not believe, and will not follow your treatment. And then the second phase, which is a fun phase for a therapist, is when you start challenging your patient to change or help them change their behaviors, right? And other researchers in the 2000s have found that you're gonna have ruptures with your patient, right? It's not gonna be a smooth journey with your patient. It's gonna be a bumpy road with your patient, but that's okay. This is okay, and we have to be aware of this, because when when you have conflicts with the patient, you know that this is your chance to make a difference with your patient, right? Instead of just avoiding it and be like, okay, there's a conflict, I don't want to see you anymore, and you move on to the next one. So Therapeutic Alliance, it's a trustworthy collaboration. It allows you to address the biopsychosocial aspect of the condition, and I deal with mainly pain, so it's very important to know what's also happening, not just at the physical aspect, but also a psychosocial aspect. And this special bond with the patient really makes them become more active and engage in their own treatment. What was interesting is that you kind of maximize this therapeutic relationship between the first appointment to the appointment number, like the 25% mark of the sessions. So if you're seeing your patient 4 times in total, the first appointment is very important because this is where you maximize it. So the first 25%, this is where you maximize the relationship with your patient. And it's okay, it's a bumpy road. It will not be smooth with your patient, and you have to accept this. Now, why talking about Therapeutic Alliance? So when I graduated from McGill, I didn't have any knowledge about mental health. Yes, I've heard about depression, schizophrenia, but we were not taught about how to deal with psychiatric patient. And so I'm getting this job, and I'm like, how I'm gonna deal with these patients. And my dad was diagnosed with bipolar disorder. Was a difficult childhood, yes, but that's the only experience I had. And today my dad doesn't take any medication. He is not labeled as a bipolar patient. He is cured. He exercises every day. He quit alcohol. And looking back, and how did he did this? It's because it's the trust he had with the physician, with the family members, the support he had throughout his journey made him out of this condition. So this is the only experience I had in mental health before starting at the Douglas. This is what the physio department looks like. And the bars are very special because I'm gonna come back to this. So just have a visual image of what the physio looks like. So my first patient. So I arrived in the hospital. I'm like, okay, I don't know, like maybe someone's aggressive, and I'm like, pumped, and like, okay, Schizoaffective disorder is a 60-year-old lady with multiple suicidal thoughts, paranoid, disorganized, agitated, anxious, irritable, altered judgment. I walked there, saw her on the wheelchair, long, white, beautiful hair, sitting on the wheelchair, long dress, looks at me, and I'm like, said hi. And she looks down, and I'm like, okay. I'm like, hey, my name is Karan, I'm a physiotherapist. Looks up, va-t'en. Go away. I'm like, okay. And she was referred for physio because she didn't stand or walk for at least 2 months. So by the time I got to her, maybe it was 3 months, 4 months. Not standing. She said, and with time I'm like, why don't you stand? Why don't you want to walk? And she said, I'm too scared to fall. There's too many people around me. Go away. I keep hearing voices telling me that I will fall. Someone will cut my legs, or a bus will hit me. My knees will give away, and I'm pregnant and I have 6 babies that I'm carrying. It's not true. It's not true.
He gives you that.
It's not true. Yeah. And I'm like, how do I gain her trust? So I kept my session very short. And I know maybe it's not the thing to do, but I just needed to find this emotional connection with this person. I need the first trust is very important, and I was just looking for this. And even if I kept the session short, I just wanted to gain the trust. That was my goal. I brought her in a very calm area, the physio department. There's no one, put some music, no distractions. She used to love music. She studied music in CEGEP. This I knew. I read the story, the history. And she's on the wheelchair. I'm standing. I'm like, maybe it's not appropriate. So I knee down. And I made sure I was eye level with her throughout the session. Because looking through the eyes for me is connecting with the soul of the human being. I was very respectful, even though she was sometimes aggressive in her wordings. I was still calm, even though she was agitated. I was patient, because you have to, because it's a bumpy road, right? And you have to be open-minded. They live in their own world. She thinks she is a bird, right? She's a princess and she owns a castle. Let her be. And the fact that she thinks she's a bird, I use this, like, not against her, but to do some balance exercises with her. So I was smart. I still educated this woman. Of the importance of, like, muscles, because this is what you need if you want to stand and walk. I educated her. I don't know if she's listening to me. I don't know if she understands what I'm saying, but I still educated her, like I would do with anyone, right? And when hearing voices, because she eventually stood up with me, and we did few steps together, and she said, stop. I'm hearing voices, people saying, I'm gonna fall. And then my reaction was, I was closer to her, looked her in the eyes, and I said, let's prove them wrong. Let's prove the voices wrong, and let's walk a bit more. And we did. And a month later, she was autonomous. She was able to stand by herself from the bed to the wheelchair. She was sitting alone, walking in the room, just a bit, short distances, but she was walking alone with a walker. And I put her on a list with where PABs could walk with a patient. She would maybe walk, I don't know, 5-6 steps, but that was a lot, right, for her. It was a lot for her. So that was my first encounter with a psych patient, and this is when I realized that if you have your patient trust and you give them some hope, then anything is possible, right? And maybe it was just a fluke. So I went to see, so I started, working with other patients, and there was another man, Mr. A, 61 years old, intellectual disability, schizoaffective, aggressive, inappropriate behavior, slur, and I was not able to understand what he was saying of his slurred speech, and also all the disability that he had. And this man, before he got many hospitalization in the past 2-3 years. Before that, he was walking alone, slow but walking. He was calm, respectful, no change. The behavior was good. After many hospitalization, not at the Douglas, different hospitals, this and that, with medical, some medical mistakes based on what the family was telling me, patient was unable to walk over a year. He was on the wheelchair with a belt, right, in bed, attached. And he was referred to me because the patient didn't walk for a year. So I took the referral, went on the unit. So at the Douglas, it's a huge tunnel that connects to different units. So I was walking, looking at this. I'm like, didn't walk for a year. I'm like, okay. Kept on walking, and then I'm like, okay, I don't know how I'm gonna do this. And then the first encounter with the patient. So the patient was in his bed, attached, went with the nurse, saw the patient, and I'm like, Mr. A. And he's attached to the belt, and he's like, he turns, And he turns back again, so he doesn't want to see me. I said, okay. Then I'm like, my name is Karan, I'm a physiotherapist, I'm here to help you walk again. Looks at me, and he started throwing me something, a tutu. I think he had a teddy bear, it's a policeman or a firefighter tutu. He started throwing at me. And I look at the nurse, I'm like, what do you expect from me? What do you expect from me? And he's like, it's okay, we're gonna tell the unit, it didn't work, it's fine, we tried, let it go. I'm like, okay. So then took the tunnel, went back to the office, and so I'm starting this job, I'm like, it's a nice challenge, I'm not gonna lose easily. So I have to find a way to reconnect with this patient. And so what I did is I called the unit and said, I'm gonna come try again 2 days later, because I work every 2 days. Went there again, same thing happened. And I'm like, I don't know, I don't understand this. Went back to the office, called the unit, and I said, bring him to the physio department. So 3rd session, 4th session, nothing happened. He doesn't want to listen, there was nothing going on. I did all the, at the eye level, everything I was trying to connect with this patient, and it didn't work. So 4 sessions. So then I'm like, should I just quit? But I'm like, no, I want to try again. So 5th session came, and he stood up with the help of 3 people. 3 people. I didn't care. He stood up. That was the most important thing for me, on the bars. And that session lasted 10 minutes, I think. But he stood up, put it on the wheelchair, and I told the team, you could take the patient to the room. 6th appointment. And so when he stood up, I knew that his extensions of the knee, so he was standing with like this, with some, he was missing extension, basically. So I'm like, okay, I have to work the extension. So 6th session, he came back to the physio department, and I put him on the mobility bed that we have, and I started working on his knees to try to straighten up. And this is when I realized this patient trusts me. He's able to let me touch his knees, and that's important. In physio, we touch a lot, and that moment, I realized that if the patient lets you touch, it's because they trust you, right? And then came the 7th, Then came the 7th session, 8th, and he started walking alone in the bars, and then with a walker, with 2 person, then 1 person, and then alone. And then I was watching him walk in the corridor. Started walking 10 meters, then 20, then 50, then 70. Then he was doing 400 meters. And how did I gain his trust? Again, kept the session short, gained his trust, walked in a very calm area, put some music, eye level, respected this guy, this man. I was calm, I was patient, open-minded. I let him be in his world. He still thinks that he's a firefighter, and he sees firemen everywhere. And I said, and I've been telling him every time he says firemen, I said, yes, they walk and they're strong people. So, I need help because he ended up walking. So after 3 months of rehab, twice a week on average, because sometimes it's three times a week, sometimes it was once a week, but on average, he was autonomous with the walker. He was walking 100 meters 4 times with me, also seen in the units walking by himself. He was autonomous in his transfers. He was with the belt in his bed, bound to the wheelchair, and he was able to stand he was able to stand by himself, going in and out of the bed by himself, going to the washroom by himself, taking off his pants, sitting, standing, flushing, washing his hand by himself. We take these things for granted, but those are big victories for some patient, right? And so in early 2019, he was discharged in a group home because he was no longer qualified for a poly-handicapped house, which is a big thing for him and also the family. And I didn't achieve this alone with this patient. The family was there all the time, helping the patient during the physio sessions, outside the physio sessions. Even today, I saw the family and the patient at another hospital, the Lakeshore Hospital. The family is so involved, and I think that more we stay connected, more support that we have, you could achieve great things, right? And this again, I realized that if I have this patient trust and give them some sense of hope, then anything is possible. And the last patient, very, very special to me, as a sociology teacher. She surprised me. She's sitting here today, so thanks for coming. So she walked in the physio department, showed me a doctor's prescription saying that, s'il vous plaît, évaluation physio pour trouble de conversion. It's a trouble de conversion. It's a mental condition where a traumatic event, stressful event that happens in your life, and suddenly you start having symptoms, neurological symptoms, paralysis, or many other symptoms. But she presented with this rigidity, difficulty speaking, freezing of gait, freezes in small areas, especially the doors. Opening a door takes 3 to 5 minutes for her. She doesn't know how to do it. She freezes. She sees this door and she's like, I don't know what to do. And I'm like, try, 3 minutes. And I'm like, okay. So this is the first time I saw this patient. And so the psychiatrist is telling that she has conversion syndrome. Another doctor says she has Parkinson's disease. Another doctor says she has progressive supranuclear palsy. And so she's telling me this, and I'm like, I don't know, what should I do with you? And I remember she asked me once, do you know what conversion syndrome is? I'm like, yeah, I heard of it, but I didn't know, so I lied. And I lied because I didn't wanna, yeah. And so, she saw this in my eyes that I was lying, and she said, conversion syndrome is And about this, I went to see our most experienced psychiatrist we had in the hospital, and I said, I have this patient with this, what should I do? And she's like, where did you find her? I'm like, what do you mean, where did I find her? She said, the first and last time I had a patient with conversion syndrome, it was when I was a student. And I think she's like close to 70, 73 years old now. And I'm like, okay, so there's no help from here. Now she has different diagnosis, right? Should I treat her as a Parkinson's? Should I treat her as a PSP? As a conversion syndrome? Like, I have no idea. And then I asked her, what's your goal? And she's like, I want to walk again and teach again. And I'm like, okay. So the first sessions, I'm like, let's try to build some trust here. And I told her, listen, I can only help you to improve, hopefully to improve your signs and symptoms, and hopefully this will improve your condition, because I don't know what you have, but I can't cure your Parkinson's, but I could help you to manage with the signs and symptoms, and hopefully, with time you get better. And once I gained her trust, I started to challenge her thoughts, focus on being positive, because at the beginning it's it's frustrating for the patient. I'll be able to do certain things and start crying and being very negative. And for me, I'm like, no, be positive, focus on positive. You did 2 steps without freezing today. You did 3 steps today without freezing. You were able to go, it used to take you 3 minutes to go to open a door. Now today it's like, took you a minute and 30 seconds, So small gains like this, I reinforced her every time and corrected her every time she would make a mistake. Every time we make a mistake, so let's say turning, the people, they turn like this. I'm like, no, this is not how you turn. So correcting mistakes. So I was doing all this. I don't know if that was the right thing to do. I haven't read anything about it. I just went with what I see and my expertise in physio without knowing exactly what she has. She's human. So this is how I treated this lady. And I want to show you 3 videos. The first, maybe not the very first time that I saw her, but at the very beginning. Watch at the walking pattern. Can you please click? So basically you have to go for from the green one to the blue one. And it's not happening. There's a freeze of gait. Okay. So that was July 4. Then a month later with physio and then working on the gait and gaining trust and this is what we managed to do. August 6. Then August 22, same year, nice walking, yeah. I cut the volume because she said, please take the red shoes, I want to see the red sandals. She would freeze here. There's a door coming. She would freeze. But she didn't. And she's here. She's here today. So twice a week for a month, she went to teach for one semester. One semester. And, after this, it's an up and down again with conditions. But maybe today she's a bit far from this, but this is seems a small thing for all of us, but it's so big for her, and so I'm happy. And again, if you have your patient trust and give them some sense of hope, then anything is possible. So what I learned in mental health, you have to accept and respect, respect who they are as an individual. They're humans, not diseases, not disorders, not diagnosis. And let them live in their world, right? If they think they're a princess of a castle, let it be. If they're a fireman, let it be. It's a bumpy road, it's, if it doesn't work today, just say it's not a good day, try again, right? And give them multiple chances to succeed. It's important. We with all our knowledge and background and research we know, and it's okay. It's okay if your patient doesn't comply to your treatment. Just give them chances to succeed. And always achieve trust. Even if the session is 1 minute, achieve the trust of your patient. You want to connect with their soul before you do anything else. Because if you connect, then your medication will work better. There's a placebo effect too, right? In all medication. And then you challenge them. So this is the fun part. You have to believe in them, and you have to make them believe in themselves too, right? Has to go both ways. And always be at eye level. Now, standing here, patient on the wheelchair, sit down, sit down, be at eye level. This is how you connect with your patient. The importance of touch. When I placed my hands on this man's knee, this is when I knew that I had his trust, right? Body language is important, right? And be humble, be honest. We are in a great field with great people, right? And we have to show the same amount of respect to our patient that we're showing our colleagues, our family members, and we gotta put everyone on the same level. And also know that you cannot fix everything, right? You cannot fix everything, but it's okay. You still have to try your best and, you know, be passionate and be the best of what you can be, and try to help your patient the best you can. And educate. Even if they're mentally ill, you could still educate them. Take the time to educate your patient. It is very, very, very powerful. Reference, and thank you.
I just have a little comment to say for Karan. I really, really want to thank you for that, because I myself am a physical therapist as well, and I realize our profession, we're really fortunate that we have the time to spend with patients, especially in the context of mental health, that we can, you know, accompany them and spend an hour. And even if that hour means we're not going to necessarily do range of motion or squatting, you know, it might just be speaking with them. And so I just really appreciated and your talk to know that you do this, because I work in the acute care setting in a hospital and emergency. So even though I have the desire to do what you do, I just can't. So good to know that you do, and I'll probably be sending you some patients.
First of all, thank you all of you for these wonderful presentations. My name is Ashley Davidson. I'm an oncologist. So naturally, one of the first things I thought about was the vignette that was presented by the first presenter. But I want to start with the last presentation. And Karan, I was astounded by how much of your last slide, what you learned as a physiotherapist in mental health, applies almost exactly to what I do, and how much I can be taught by that last slide as an oncologist, doing something that is ostensibly so different from what you do, but almost every point on that list was something that I could take and that I can learn from. And likewise, going back to that first presentation, I was struck most in the vignette by the fact that the patient left the encounter feeling that she or he had failed. And I think you even used the word failed in the presentation, and it was astounding to me that a patient could leave an encounter with me or with a physician and feel like a failure. Happens to me semi-regularly. But as a patient, it never occurred to me that they could feel that they could control an appointment or could direct an appointment and thus fail to do that given the opportunity. We feel that we're in charge of those appointments. But it reinforced to me that what patients really want to feel, almost above all else, is they want to feel cared for. And when patients drive through the snow, get up early in the morning, drive through the snow, park their cars, walk from their cars to come in to see us for those few minutes, what they want to feel is cared for. And in that encounter, the provider had failed to make that patient feel cared for. Now, I'm not going to harp completely on the fellow, because I appreciate the person who stuck up to defend the fellow. But that fellow did fail in that encounter, and as we all do so often. So the 2 points that I'll make about that are, the first one is the continuity of seeing the same provider each time. Someone brought up that point. And what I try to do in practice is I try to, even if I have an advanced trainee who is excellent, who's competent, I try to, and it's not always easy, to see that patient at least once at the end of the encounter, just to either poke my head in or say hello to that person, so that that person knows that the person who's quote unquote in charge of their care is still there. And it's not easy to do. When you're behind and the fellow has expertly managed the appointment, and you just want to move on to the next patient, I don't always succeed in forcing myself to do it. But I try to, because that little point of contact establishes that continuity. The second thing that I would bring up is what was mentioned in the second presentation by Dr. McDonald, which is that words matter. And what that fellow said was not, what that fellow implied was not inappropriate. To say that that person needs to see a counselor is maybe quite appropriate. But whether you say, in a time-pressured environment, whether you say, what you're going through sounds incredible. You've been diagnosed with this cancer. I know what other challenges you have in your life. It's astounding what you're being asked to deal with right now. I know you feel very well supported. I've met your husband or your daughter, but sometimes it helps people to actually speak to a professional about these kind of things. To say it that way instead of saying, do you have any help, has a very, very different impact on the patient and doesn't take that much more time in a pressured environment. So from a medical education standpoint, what we would teach the residents, I think that's an excellent moment to teach fellows, to teach residents that these communication elements are actually skills that can be learned and can be practiced. And that's something that we endeavor to do in our practice. So thank you very much for all of you for these wonderful presentations.
Thank you, Ashley. We have one more question.
Well, just one more comment.
Mike.
To the point of failing that day, my daughter taught me, in thinking of our other daughter who has a disability, Mom, not today doesn't mean not tomorrow. And I say that a lot.
No, go to the microphone.
With regard to the first patient you discussed, Mrs. Levac, a patient with breast cancer which is advancing and is not responding to treatment, it seems to me in many cases the doctor is really not the best patient, is not the best advice. The patient has escaped medical therapy, or may be. What should one refer? I mean, maybe you should see a priest rather than a doctor. Does that come up?
Please defend me.
Oh my God. Well, I think it goes back to, you know, what's been talked about here, which is the importance of a connection and the importance of a contact, the importance of both people being, you know, involved in the tango. It doesn't mean to say she shouldn't see a priest. It could be a really good idea. But I think we're talking about the importance of relationship, the importance of establishing a link. It's interesting because when I see patients for the first time, I often say to them, you know, if you don't feel sufficiently comfortable, we need to talk about it, and I will find someone else for you. Because, I mean, obviously, I'm in a different business. You know, there are people, you know, you have patients, you have to see them, but I think it's really important. I think it's basic, completely basic to, I think what's happened is that the person of the physician has become so much less important. What's become important is the technique and the ways of doing things. And I think, you know, to re-put in the highlight, if you will, the importance of the person of the physician or the healthcare professional, the physio, I think is absolutely key.
May I actually speak to that comment and perhaps add to it? As physicians, I think we've lost the ability to teach how to care. So we really do everything on a very medical level, but we've lost the ability to show empathy and to show care, which is a serious detriment, because most people, when they go for their medical school interviews, will say, well, I care. You know, I'm going in to help people. And we somehow manage through medical school and residency training to have people become much more sterile in their interactions. So you have to remember, sorry, that it's very important to show in this encounter there was no caring. It speaks to in English, and I don't know how it is in the States, but we fill out what's called the level of care form, right? Which is a horrible misnomer. it should be the level of aggressive intervention, because if you tick off number 1, well, we're caring the most, and if we tick off number 4, or 5, it's palliative care. We should always care, and so perhaps a priest might be the appropriate person for this patient, but in fact, the physician should always still care and should be able to show through body language, through speech and through touch, that they do still care about the patient. And I think that's really getting lost as people go through their training.
So I guess when somebody was bringing up medical training, you know, and how some of that empathy or some of those communication skills are not always being taught optimally. And one thing I really became aware of when I was working with patients and trainees, but most of all colleagues, is that sometimes some interactions that happen are really not interactions we should be proud of. And I believe in leaving kind of my stuff, you know, kind of as I walk through those doors. I'm there to do a job, and I'm reminded that we're always on. So as staff people, we are always on. So we are always being a role model to someone, and I think it's just really important to remember that. Because I think trainees we talk about patients, and that's very important, but trainees may not remember what you said. They may not remember what you tried to teach them that day in terms of factual knowledge, but they will remember how you acted. And they will remark on that at some point. So often when you're doing their final evaluation, they may tell you about something that struck them, and it may not be a positive thing, but trainees are very good teachers. I talk about patients being my teachers, but I just love working with trainees so much because they teach me and they help me redress sometimes things that need to be redressed. Yeah.
So I always wanted to be a doctor, and even today, but I asked Cristiano yesterday, we're sharing the same room, and I asked him, will I make the same difference if I become a doctor one day? You know, it's a question that I'm asking, and it goes back to maybe, I don't know, the kind of training, because we select students because, you know, they care for their patient, they all the good things they say, and they are caring and all that, but what happens throughout their training? What happens once they start practicing? What happens, you know, with 10, 20 years of experience? What happened to them when they started with being like, yes, I want to care for my patient, I want to be there, I want to listen to my patient? What happens in their journey? And that's a question I asked Cristiano. And I also asked him, is it getting better or worse with time? Because I don't know. I just started my practice. It's been 2 years, so I don't know where we're heading, because one day my turn will come, and a doctor or a medical team will take care of me. But if I'm seeing all these things today, I don't know where we're heading in many years, right? So I don't know. It's just a comment.
I'm the daughter of a doctor, and I just wanted to thank you, give you just a little example of some of the ways that I learned how to care for people. One of the last things that my father did as a doctor was the night before he died suddenly from a heart attack. He stayed up all night playing cards with his intern because his intern was going to be losing his first patient in the hospital. And my father also, this was my father's patient as well, so he wanted to be there for his patient, but also for his intern. And that's just a small example of what I saw from my father. But it's such a beautiful opportunity to be in contact with our patients the way that we're given, and also reminded me that every single thing that we go through is something that is really truly for us. And I really wanted to thank all of you for all the many examples that you gave of how your patients, we often think of coming to care for somebody, because that's why we get into this profession, but how much they really are for us too. So, thank you.
Quickly, just a little comment on what you just said and what Nick Newman's question. But I'm a nurse. I work in emergency medicine, and I'm also currently doing my master's in administration of healthcare services. And a lot of people ask me, like, why are you doing this? You know, management, you're crazy. Like, why would you go into this field? But the more and more that I learn about how our system is built, the more and more I realize that the conditions in which we are put to work kind of push us to care less and less, you know? Just like in the emergency department, you add, obviously we want to see more patients, but that means less time for the others, which means less caring happening. And so I think there's also a huge role in, you know, leadership in management, you know, to try and put in place structures that could enable us to care more and more for our patients. So I think that's one step also in Karam's question, like in the future, if we want to continue being human and this approach, it's also going to have to come top down from management. So.
Okay, I want to thank you for everything. It was very, very interesting. I was thinking about the main thematic that you speak about, and it was about trust, and it was about related to others. If you don't understand, then you can't translate, Christian. And I, as a psychologist, clinical psychologist, I had a lot of challenge. And I always want to know, I think that each of us had to develop our own relationship with our patient. And this is not easy, and it's long. So how do you can do that in your own work? This is a big challenge. And my challenge, I try to say I have my own tools and the patient have his own tools. So I remember when I had a very, very big challenge, and it was an adolescent who made rapes. And it was very difficult to have reached or develop the therapeutic alliance, because he knew that there was been a prison or, you know, like centre d'accueil in Quebec. And it was, I had to do the work for the psychiatrist, so the psychological testing. And I didn't know how to make the relationship with this adolescent who was he was just in front of me, you know, in this position, and said in his mind, no, I will not tell anything, because, you know, he didn't have his own process with the judge. So I thought about that, and so I think it is very difficult to think about that. It's outside the work. So how can you do that? But me, I try, and I said, okay, I will do the intellectual cognitive test, and I will try to have a relationship with him. And at the end of that, I was supporting him, taking my time, even if the time is really short, you know. And I said, you know what, I don't understand why you don't go to school, and because he was not going to school, hiding this to his parent, you know, and he was changing the phone and erase everything from the school. And it was the first thing that he had in his mind, that he was intelligent and he can do something. And after that, I was able to go through the other test, and it became very easy after to tell him what would be my recommendation for the judge. And he had to accept that. And it was, you know, like the intervention plan. It was very difficult, but, you know, I told myself, thinking about your work, that it's very difficult because you have a lot of work to do, and it takes, you have short time to do the alliance. So I think it's very important to think about how we do that after saying that it's the most important tool.
Thank you, Luis. I'm afraid we need to close. I just want to say one thing, and we're running late, but I want to defend the fellow in saying that, again, like we learned from Karan, patients see when we lie. And for them to feel that we care, we need to care. It's as simple as that. So I've been guilty of nodding while thinking of what I was going to have for lunch in front of her. And patients read through you, and maybe they forgive you, hopefully. But what I'm trying to say to Nick's comment is that the patient was not the only victim of that failure. I think the fellow was the other victim, because he lost an opportunity to be changed for that encounter. Christina.